So let's go on to the next talk, okay?
So this is exciting because even in research, if Dr. Heuser did this PQ bypass on 100 patients, and at the end of 1 year he had only 50 patients in his study, what's the guarantee that the other 50 did not die because of your procedure?
Because I said they didn't. Two things. Number one, the most important part of any new technology is the need. Clearly, we saw from that presentation, there's a need. And speaking of the need, we need our fearless leader to give us this talk on an update of a novel endovascular technology by Dr. Venkatesh Ramaiah on the Nectero E-system for slowing abdominal aortic aneurysm growth. Thanks, Venki.
Thank you, Rich. So I do have a conflict here because I'm involved, I'm a consultant, and I'm an investor too. So as a vascular surgeon, we fix aneurysms and we do complex aortic surgery, but we've really not gone to the crux of the problem as to why do these aneurysms even occur, and can we stop them from growing? We have all this fancy technology to fix them, but we've never gone to the root of why these happen and how can we treat them. So right now, aneurysms less than 5.5, which is the standard to fix them, are just monitored. They don't get any treatment apart from control of blood pressure, coronary disease, exercise, stop smoking, and things like that. So those aneurysms, say from 3.5 to 5 at least, are just being monitored right now. And if you look at the predicted rate of growth of these patients, you will see that patients with a greater than 4 centimeter AAA, the trajectory of growth will likely reach 5.5 centimeter threshold at 5 years. And the average of diagnosis is 71 years old. Slowing the growth of these aneurysms by even 50%, and if you can do that, extends the time to reach that threshold for fixation to greater than 10 years. So that is the whole model of what we are doing here. There have been a lot of drugs, rapamycin, one of those diabetic drugs, aspirin, metoprolol, all of these to try to reduce the size or prevent the growth or stabilize the growth of these aneurysms. This is a novel drug. This is called 1,2,3,4,6-pentagaloyl glucose. I don't even know what that means, but it's called PGG. What PGG does is it strengthens the weakened tissue. It basically causes cross-linking of collagen and elastin, and it theoretically hinders enzymatic degradation. It inhibits the growth of these aneurysms, it reduces the risk of rupture, and it strengthens weakened tissue. This was actually a very toxic substance. It was used in the tanning industry, and now it has been purified. A lot of this work was done at Clemson, South Carolina. So what we do is, and for full disclosure, I've done the first 20 or so of these first-in-human cases, all the way from Hong Kong, where did I go? Colombia, Latvia, and things like that. So basically, we take these aneurysms anywhere from 3.5 to 5. We get access, which is like a 14 French sheath. We put in a balloon occlusion right below the renal arteries, and then below the renal arteries, there is a perfusion balloon. So we inject this drug called PGG through this perfusion balloon over a period of 3 minutes at a pressure of 60 to 80. And that allows this drug PGG to infuse into the aortic wall, through thrombus also, into the aortic wall. The procedure takes about 10-15 minutes, and then you put in a ProGlide. Patient stays in the hospital because of this is a first-in-human studies. And so we've done a total of, I think, 42 so far. So this is the basic principle. Procedure takes about 45 minutes to an hour. It can be done with general or conscious. It's delivered through a 14 French sheath. Any large bore closure device can be used. Thrombin does not pose a barrier because we had one patient in Hong Kong, I think, who passed away from COVID, and we did an autopsy on, and you could see PGG in the wall of the aorta, and she had thrombus. So we know that this drug diffuses through thrombus into the aortic wall. It does not leave any permanent implant behind, and basically it's a very simple procedure. So this is our first-in-human study. There were 6 sites, Latvia, Hong Kong, New Zealand, Australia, and Colombia. There were 46 patients enrolled. I think this is updated. Last time I presented, it was 42. Aneurysms from 3.5 to 5.5, 30-day follow-up, and we are following them from 1 to 3 year follow-up. And then we are looking at the change in diameter, and we are looking in reduction in rate of aneurysm sac enlargement, and we are following them for up to 3 years. So if you look at the outcomes, technical success was 100%, safety for 30 days. We had 1 death from COVID, which I mentioned. We noticed that there's a transient elevation of the liver function test, but they come back to normal within 24 hours. But the rest, we had 1 patient with a very minimal atheromatous embolization to the toe and 1 puncture site infection that was discharged with antibiotics. So this is how we look at the data. So we sort of categorize them to aneurysms greater than 42.5 and ones less than 42. And if you look at the projected expected growth greater than 5 millimeters in diameter, you will notice that there has been a significant change in the annual per millimeter growth. And you will see in the next slide, if you look at the natural history of growth of these aneurysms, which is in the red, and you look at 50% reduction, which is in white, and if you look at what Nectero or what PGG did in the trial, you will notice that there is a significant, not only reduction, but stabilization and growth of these aneurysms. We have had only 3 patients that completed 3 years. We've had 5 patients that completed 2 years, 20 that completed 12 months, and 24 that completed 6 months. It's a classic example of these patients. These patients are evaluated by CT, by volume of the aneurysm, as well as the diameter of the aneurysm. There is a control lab or a core lab, and so this is already being done. So with the success and the data, this has actually given, the FDA has given this particular trial, called the STABLE trial, Fast Track designation, as well as Breakthrough Therapy designation, which basically means that even the FDA and the people involved in new technology are extremely excited that this is an unmet need, and this is something that we need to look into. And so we've now started the US trial, and I enrolled our first patient. It's a randomized trial, basically, and the trial has just started. It's going to enroll a blind control trial of control as well as those patients treated, and the trial is just underway, and I think by the end of the year or early next year, this trial should be completed and we should get the data. So this is something new, this is something unmet need for treating these aneurysm patients rather than aggressively treating them with endovascular technology and then following them up too. So we're really excited about this new kind of technology with the fast breakthrough as well as designations given by the FDA. Thank you.
Congratulations, Venki. I understand if this technology had been available in 1954, 1955, Albert Einstein would be alive today. This is certainly a need, and it's certainly a lot different than being very passive and using some of the weird things we used to use in the 19th century to stop these things from growing. But congratulations. It's very exciting.